Hello, my name is Dr. Yaariv Khaykin. I'm a cardiac electrophysiologist at Southlake Regional Health Center and PACE Cardiology.
And it's my pleasure today to talk to all of you about some new developments that we as a program have been at the forefront of, namely pulse field ablation for our patients with atrial fibrillation. So I will discuss the physiology of atrial fibrillation and rationale for ablation in general, and specifically focusing on pulse field ablation, and then discuss experience kind of in the world and at Southlake. So without further ado, first I wanted to kind of set the context. I'm sure all of you know about atrial fibrillation, the most common arrhythmia, but I wanted to sort of dive in and tell you a little bit more about the mechanism of the arrhythmia. And I'm certainly hoping that this movie was running just before we started, and it's still running. Very good. All right. Let me see if I can get a laser pointer here. There we go. So in your heart, you have four chambers, two chambers on top, right and left atria, and two at the bottom, right and left ventricles. I don't see any plumbers here, but as an electrician, I'm more interested in the electrical conduction system of the heart. Electrical activity in the heart normally starts in the sinus node. It's a group of specialized cells at the top of the right upper chamber of the heart. It generates a heartbeat, slower when you sleep, faster when you're trying to run away from a tiger. It activates the upper chambers to contract and push blood through the valves into the bottom chambers. Upper and lower chambers are insulated from each other except for a conduction wire called the AB node, taking electricity through this yellow Purkinje system down into the bottom chambers, making them pump quickly to the lungs and throughout the body. And normally, for every beat in the upper chambers, you have a beat in the bottom chambers. Now, in atrial fibrillation, the picture is very different. What happens in atrial fibrillation is you get short circuits and extra discharges coming from the pulmonary veins. Pulmonary veins are these tubes here, the back of the left upper chamber, left atrium. They drain blood from the lungs back into the heart. And where the veins plug into the heart muscle, that area is very irritable. It can become more irritable if you have electrolyte problems like low potassium, low magnesium. It becomes irritable in patients with diabetes, high blood pressure, people who are overweight, sleep apnea, alcohol, caffeine, dehydration, and multiple other conditions. And when they become irritable, they start firing these extra beats. And I tell patients, it's like somebody throwing matches towards a can of gasoline. When you have one of these beats come out, it can throw the rest of the heart into this rapid, irregular rhythm of atrial fibrillation, where the upper chambers start going at 300, 400, 500 times a minute. Now, when the upper chambers go so fast, they stop pumping. So blood doesn't circulate properly. The bottom chambers essentially have to suck the blood out of the upper chambers. And with that, a blood clot can form, particularly in the left upper chamber and particularly in the left atrial appendage, this cul-de-sac right here. And there are certain risk factors like high blood pressure, being older, having diabetes, having had a previous history of a blood clot that makes somebody more likely to suffer that consequence. The other problem that happens is all of a sudden you have a really rapid rate in the upper chambers, and all of these beats are bombarding the AV node in between the upper and lower chambers. And now AV node starts conducting a lot of those impulses, and the bottom chambers start going really fast. And when the bottom chambers start going really fast, some people, doesn't seem to affect them at all, they feel perfectly fine, but a lot of people, the ones that kind of subselect themselves and actually come to see us, feel really unwell. The younger patients feel the irregularity in the heartbeat. They feel out of control, drives them bananas, stop them from doing whatever it is that they would otherwise be doing. Older patients come in feeling short of breath, tired. They think it's their age. They just can't do whatever they were able to do before. And miraculously, in a lot of those patients, when you control the arrhythmia, they feel dramatically better. The other thing that happens is if the bottom chambers see, and in some people just an irregular rate over a long period of time, and in some patients the rapid rate related to atrial fibrillation over long periods of time, the bottom chambers deteriorate, they malfunction, and the patient can develop full-on heart failure, fluid on the lungs, etc. And we frequently see these patients admitted through the emergency room. They were kind of asymptomatic or saw that they had a pneumonia. They come in, they're short of breath, they're coughing, and we see that their heart muscle function is half or a third of what it should be. They're in heart failure and they're in atrial fibrillation with a heart rate of 150 beats per minute all the time. So atrial fibrillation is very common, affecting close to 1 million Canadians, and this slide is relatively old, so the number is probably higher, particularly as the population is aging. The likelihood of somebody over the age of 40 to develop atrial fibrillation is 1 in 4, and in the population over 80, about 10% of those over 80 have atrial fibrillation at some point in time. Now, there are medications that are used to thin the blood to prevent stroke. There are medications that control conduction through the AV node to slow it down. There are medications that we call antiarrhythmics that help control the rhythm and keep somebody in rhythm. Unfortunately, those are only about 30 to 40% effective over time and not the focus of what I'm going to be talking about today. We know from studies that were published originally around 1998 that pulmonary veins are, is the region responsible for developing atrial fibrillation in most of those patients. About 95% of the extra beats that cause atrial fibrillation come from the pulmonary veins. And so over time, techniques and technologies have been developed to electrically isolate the pulmonary veins. They're still physically connected, but no longer electrically communicating with the rest of the heart in order to prevent episodes of atrial fibrillation. I trained to do these procedures at the Cleveland Clinic as a fellow, and the first procedure at Southlake was in February 2004. So we're almost 21 years into our AF history. We started these procedures at about 8 o'clock at night with Zave down in the old DI room. And in the first year, did about 50 procedures. At that point in time, TGH had done about 15 procedures before we started the program here. And over the last 20 years, we've grown to the point where this year we're on target to do about 1,000 AF ablation procedures at Southlake. Now, the conventional AF ablation procedure involves, putting the patient to sleep, putting some freezing around the femoral vein, the vein in the groin, putting catheters, thin wires, with a whole bunch of guts, electrodes, and sensors, and all sorts of other stuff inside of the wire that are very expensive to the hospital, into the heart. We put them through the vein in the groin, through the right upper chamber. We poke a little hole in the wall called the septum between the right upper chamber and the left upper chamber. This hole heals very nicely, and the procedure is called transseptal puncture. Used to be very unsafe, but over the last 20 years, with the advent of intracardiac echocardiography or ultrasound, we do it under direct visualization, and so it's become really, really safe. And then in the conventional procedure, we use kind of a point tip catheter to move around these veins, which we see on X-ray, ultrasound, and in three-dimensional kind of VR, XR type of space. And we cauterize tissues around the veins to create a layer of scar that prevents electrical activity from conducting in and out of the veins. Another common technology we used over the years had been a freezing technology where we would put a balloon into each one of these veins, inflate it, fill it with a cooling agent, and cool the area to minus 70, minus 80 degrees. At the interface between balloon and the vein, we would cool it to about minus 30 degrees. An ice ball would form around this actual balloon and would go into the tissues with the idea of creating a frostbite around each of the veins and killing the tissue, in the process of creating a frostbite as opposed to a burn. So these historically have been the two main technologies, and some of you in this room may have had some of these procedures. Now, pulse field ablation comes along over the last several years. In fact, interestingly enough, I'll tell you a bit more about pulse field ablation, but it was probably in a way the first way that we used to ablate even before we went to radiofrequency ablation. So with radiofrequency or burning type of ablation, what we do is kind of like a cautery. Those of you working in OR, we put current at radiofrequency between the tip of the catheter in the heart and a patch on the body. the very small surface area at the contact between the tip of the catheter and the tissue creates a lot of resistance to electron flow that increases the temperature in the tissues. We want that temperature to go up above about 50 centigrade. That causes denaturation of proteins and cell death. Before radiofrequency came about, if you can believe it, what people did was called DC ablation, or direct current ablation. They would actually plug the catheter into a defibrillator, back then a monophasic defibrillator, and deliver a shock through the tiny little electrodes at the tip of the catheter, creating a bit of a plasma ball that ablated the AV node at that point in time. They didn't do kind of multiple points. They just did like one big bang ablation for the AV node as one of the therapies. And most of the time, the patient survived that procedure. Now, more recently, research showed that if instead of developing this huge big waveform all at once, you take that energy and you break it up into a whole bunch of little trains of waveforms that you deliver with a certain recipe, what you can do is create an electric field around the electrodes. And that electrode field can essentially puncture pores or open pores in cell membrane, allow the electrolytes to leak in the wrong direction, and that then causes apoptosis and cell death. Now, it can be reversible or irreversible, depending on the field. You can open up a little bit, a few of these pores and cause for some electrolyte leakage, but not enough, and so the cell can fix itself after you're done. Or with enough energy, you can do it, to the extent where the cell would die in the process with disruption of the physical integrity of the cell. This is just a really cool video, if it plays, that is an animation that shows you what that would look like, and you would be able to see a pore forming somewhere about here sometime now, and what that might look like. And those little green and yellow balls are sort of the electrolytes that are now flowing in the wrong direction through the spore that's opened by creating the electric field. In the actual tissue culture, you can put a dye in that can only light up once it enters the cell, and what that shows is, again, the field is delivered. The dye that otherwise was invisible enters the cells, and you can see the cells that are absorbing it because the current was delivered and the field opened up those pores. Now, depending on how you deliver the energy and how much energy you deliver, you go from reversible electroporation, so the cell can fix itself after you're done, to irreversible electroporation. But if you do too much, you get back to kind of the original DC ablation type energy delivery and cause thermal injury, and that's something that we want to avoid. So there is sort of a sweet spot where you deliver the energy in a way where it kills tissues without causing significant thermal injury. And it turned out that you can fine-tune this energy delivery specific to the electrodes that you're using, the electrode configuration, electrode size. You can deliver it in a monopolar, biphasic, bipolar, monophasic, biphasic type of pattern, and 2 trains, 5 trains, 10 trains, however which way, with different frequencies between the trains, in order to specifically target different tissues. And currently, this type of approach is used in oncology and in cardiology, with the idea that the energy that we deliver only affects the cardiac myocytes that we're trying to target and kill, and doesn't affect any innocent bystanders, blood vessels, nerve tissue, esophageal tissue, etc. And the companies that develop these technologies have been able to achieve it. So some of the field complications of the traditional thermal ablation, be it radiofrequency or cryo or freezing ablation, some of the complications have been narrowing of the pulmonary veins, because as you know, when you pour some, boiling oil on your skin and it shrinks, the same thing happens, and hopefully you don't do that, the same thing happens in the vein. If you burn too deep in the vein shrinks and you get pulmonary vein stenosis. If you're ablating very close to the esophagus, the food pipe at the back of the left atrium, you can potentially damage the lining of the esophagus and cause a fistula between the esophagus and the heart. Those are very rare, but very real complications related to thermal ablation. And the one that we discovered more so with cryo than with radiofrequency is damage to the phrenic nerve to the diaphragm that goes right in front of the right upper pulmonary vein. Now, with pulse field ablation, it doesn't happen because the energy is tuned to just damage the cardiac myocytes. There's been zero permanent phrenic palsies, zero pulmonary vein stenoses, and zero esophageal fistulas in patients who've been treated using that energy. So these are kind of the most dreaded complications of the procedure, and they've been effectively eliminated using that technology. Now, because there is many different ways to deliver the waveform, we went from it was very easy to understand radiofrequency and cryo. You're heating, you're cooling, kind of different companies, different catheters, but kind of the same recipe. Now with pulse field, every company is developing their own catheters and their own recipes. And it's the equivalent of having magic potions and magic wands, because while they tell you how much energy they're delivering, the way the energy is delivered is completely different between the different platforms, and comparing them directly becomes very, very difficult. So there are 3 platforms that are currently approved and on the market in Canada. Southlake had particular experience with this platform. The catheter used here is called PulseSelect catheter from Medtronic. It's a circular catheter with a number of electrodes. You can see it being placed over a wire into a pulmonary vein. Then this electroporation energy, pulse field energy, is delivered through the electrodes around that catheter. The catheter is turned around the vein to make sure that there is good overlap between lesions. It's pulled a little bit back outside of the vein, and lesions are delivered a little bit more proximally. It's repeated for each of the veins, leading to pulmonary vein isolation. Atul led a large multi-center study when he was here with this technology. So Southlake effectively was one of the first sites to use the technology, and actually my dad was one of the first patients who happened to be in the study of this technology at our hospital. We are currently using this technology as part of a pilot. This again just shows you a slightly different perspective on it. The catheter has a slant to it, and that allows you to pull the wire out and to position the catheter along the back wall or other parts of the heart as well, and deliver lesions outside of the pulmonary vein. Now, the downside is to really see the catheter well and stay efficient with it, you have to use fluoroscopy. And so this is what we would see when we do the procedure. We'll put the catheter over a wire into a vein, we rotate it, we deliver lesions. The lesion delivery is pretty quick. This just shows it to you in other veins. Here, we'll look at the catheter by intracardiac ultrasound or echo. One of the catheters we put into the heart allows us to monitor what's actually happening inside of the heart with ultrasound, and you can visualize the catheter right here. We want to make sure to use the ultrasound to see that it's sitting right on the tissues. We can't quite see it with fluoroscopy, and the reason why that's important I'm going to mention a little bit later in the presentation. So you can see here that the catheter is in good contact with the tissues. Now, we're able to follow the catheter with 3D electroanatomical mapping systems. Again, we're one of the areas, we've been playing around with essentially virtual reality type technology since 1998, give or take. These are fairly sophisticated. They use magnetic guidance and impedance guidance to allow us to create 3-dimensional, very colorful maps of the heart that can represent electrical activity, normal voltage, abnormal voltage, the activation pattern around the heart, and we can also have the positions of the catheter on the heart in real time. You can see this is a little overdone. Typically, these procedures are about 40 lesions, but some centers kind of go a little more aggressive than others, and we know that up to about 140 lesions have been delivered by some operators kind of in the world. That also allows us to check to see what happens after ablation. So for each one of these maps, in this particular mapping system, purple represents normal voltage, and gray represents scar. And you can see that when you start from these are the pulmonary veins here, just to orient you, at the back of the left upper chamber. you did this and delivered energy to all of these areas, and then you map again, you can see that entire area is now scar. There's no electrical activity here. You can see same here. You can see same over here. Now, in the study of 300 patients, 150 with paroxysmal atrial fibrillation, where it came and went, 150 with persistent atrial fibrillation, where the patient was out of rhythm for a long time prior to the procedure continuously or needed to be shocked every time they went out of rhythm. The study showed that the outcomes as far as success rates go were in line with what we would expect from pulmonary vein ablation using other thermal technologies like cryo and RF. But the safety was really, really good. There were very few adverse safety events. It was one tamponade and one stroke in 300 patients, globally across multiple centers. And then the study also showed that the system was quite efficacious or quite efficient to use with a relatively short energy delivery on average and a relatively quick procedure time. Now, the study was completed several years ago and took a little while for the system to be clinically approved. We got our hands on it in December. This is my experience to date. I'm doing my 15th case, I think, on Friday or Thursday this week. I've done 14 cases so far. The other operators have done about the same. I, at this point, only have data for my cases. And you can see that these procedures are fairly efficient. Thinking back, original radiofrequency ablation took about 2+ hours for us to do between mapping, ablating, etc. Cryoablation took that down to about an hour. We then went to doing radiofrequency ablation, but really cranking up the heat, so to speak, increasing the power we delivered from the catheter, and we took the radiofrequency ablation to also about an hour. With pulse field ablation, we're now talking about, in these 14 cases, average fluid time of about 10 minutes without an electroanatomical mapping system, average time in the left atrium of 35 minutes, and procedure time typically under an hour. The other system that we had an opportunity to have experience with is the Boston Scientific Farapulse system, and you can see that the catheter that's used is entirely different. Again, each company is developing their catheter, their waveform, etc. So really very difficult to compare these technologies because kind of almost everything apart from the pulse field label is different between them. This system was developed from the ground up to deliver pulse field energy. This is sort of the timeline of the studies and the number of patients enrolled in these studies over time. And the commercial experience with the system in Europe, this is the first system that went live in Europe several years ago. At this point, it's over 120,000 patients. You can see that going from standard RF, as I was just saying, up to 162 minutes per procedure, to cryoablation, about 80 minutes to 120 minutes per procedure, high power ablation, about 70 minutes. In our case, our times were a little shorter than that. And then going into the incremental experience with the Boston Farapulse system, took the cases down to about 27 minutes in the literature. And I dare say that this is reproducible, and we were able to achieve similar efficiencies, as I will show you. Manifest registry of the Farapulse system included 17,000 real-world patients. And it was really primarily a safety registry, not so much necessarily an outcomes registry. And what they found was that safety was amazing. 17,000 patients, the mortality rate was very low, 5 patients. For comparison, some of the American registries of AF ablation using radiofrequency, when it was given kind of to all comers across American centers. American centers are a little different. In the US, you can open up shop on any corner and start doing whatever it is you feel like doing. And so some American registries have annual numbers per center of about 10, 15 cases, and average numbers per year per operator for about 5 to 7 cases. So in the US, mortality rate can be reported in some registries as high as 2 to 4% with conventional technologies. So when you gave it to all comers in Europe, you ended up with very low mortality rate, stroke rate, tamponade rate, etc. And we've also discovered that while this technology allows us to avoid some of the feared complications like esophageal fistula, we did observe some new complications, which we'll talk about, such as hemolysis and coronary vasospasm, which fortunately are not typically as bad as what we're trying to prevent. A large randomized study of Farapulse technology, comparing it to thermal technology. So patients were randomized to either pulse field using Farapulse or thermal, both RF and cryo. So there were patients who could be ablated in either way, showed, just like in the PulseSelect studies, that the black and white outcomes, are you still having any atrial fibrillation or not, were in line. We're seeing across multiple studies, multiple registries, success rate of around 70%, give or take. Now, as I will show you, success is not created equal, so to speak, in that you may be having atrial fibrillation, but it also is important how symptomatic you are and how much atrial fibrillation you're having. And that's where some of these technologies do differ. But on face value, success rate is about the same. On the other hand, when you look at how much atrial fibrillation people were having when they were still having atrial fibrillation, if you were ablated using pulse field ablation, you were much more likely to have a low burden of AFib, less than 0.1%. And if you were ablated using radiofrequency or cryo, you were much more likely to have higher burden, up to 10% here and greater than 10%. And it's very important because if the burden of atrial fibrillation is low, the likelihood that you need to have further cardioversions, hospital presentations, redo ablations is much, much less. And that percentage goes up very quickly as the burden of atrial fibrillation following ablation increases. This is also illustrated here. So these are large studies of these technologies for Boston Scientific, Farapulse, Medtronic PulseSelect ablation that I showed you, and we will talk a little bit about the Biosense Webster Inspire study where they used a circular catheter to deliver their lesions. And you can see that the likelihood of having redo procedures was, again, on face value, populations of patients were relatively similar. That risk was much less in the Farapulse patients compared to the others. And you can see that among patients who went for a redo procedure, the likelihood that veins were actually isolated was higher, at least compared to the Biosense Webster technology. We don't have this data for the Medtronic patients. At Southlake, we did 45 procedures around May, June of 2024. And here's what we found. We found that our case time for all comers was under 50 minutes. Left atrial dwell time was under 30 minutes, and fluoroscopy time was around 13 minutes on average. And those numbers improved dramatically between the beginning, the first 3 to 5 cases, and the latter cases. The learning curve is very steep. Personally, I was kind of fighting with the reps, trying to do it my way for the first few cases, then eventually gave up, and the procedure became a lot more efficient and a lot quicker. So fluoroscopy time came down without a 3D mapping system to about 10 minutes or less, and PVI case time came to about 40 minutes. The time it takes in the last few cases, the time it takes from putting freezing in at the groin, patient is already on the table, so the time has already started. The procedure's already started from the patient, nursing, anesthetist perspective. Hasn't started from my perspective. So when I walk in, take that syringe, put freezing in, to when I take the sheath out for just doing my part of the procedure, including transeptal puncture, over ablation, et cetera, has been reproducibly under 30 minutes if I'm just doing pulmonary veins, which is amazing. And we haven't seen that with any of the other technologies we've used so far. Now, interesting, when you actually look at our data, you can see that kind of J. I don't know what happened to my pointer here. It's kind of this J curve. So we started out with relatively lengthy times. Over several cases, those times, came to a dip. And then we went to heart rhythm meeting last year. And at the heart rhythm meeting, everybody was talking about these technologies. And we know that in some patients, arrhythmia also comes from kind of the next most common area where the arrhythmia comes from after the pulmonary veins is the back wall between the pulmonary veins. And so everybody was talking about the fact that it's so easy and safe to ablate the posterior wall that most centers in the US just started doing it. And we found that so far out of 45 patients, actually we've done 3 since, so out of 48 patients, we've only had 1 patient who've had further atrial fibrillation and who actually had to come for a repeat ablation. And the problem with that patient was that they had a narrow strip of tissue on the back wall between the veins, which is where that arrhythmia was coming from. And so lo and behold, we come back from HRS and we say, you know what? It's so quick and we're so not in a rush because we're not allowed to do any more procedures anyway. We're just going to do the posterior wall using this technology in all the patients that we're doing. And so the times went up a little bit. So if you add the posterior wall to the ablation, you end up going to about 40 minutes, for the case time for the operator. And again, you can see that the case time, decreased tremendously from 60 minutes to under 40 minutes over this experience. And the same can be said about fluoroscopy as well. Now, Biosense Webster. Biosense Webster is a system we've been using, again, since 1998. Really cool technology, magnetic guidance that allows us to position the catheters in the heart with kind of sub-millimeter accuracy. We've gone through, I believe, through like all the iterations of their system. And they've come around with several catheters that they developed for pulse field energy delivery, including the VariPulse catheter. And now we've had a very kind of short preliminary experience with this technology at Southlake. They've enabled focal energy delivery on the point-by-point catheter that we normally use for radiofrequency. And there's another catheter we haven't played with yet called OmniPulse that kind of looks funny like this, and it delivers larger pulse field lesions. Several studies, including Inspire, that was conducted to an extent at Southlake, showed that operational parameters with this technology are kind of similar, again, around an hour for the procedure, so give or take. The advantage, and the outcomes are about the same, again, 70% give or take long-term outcomes. The advantage with this system is you can do it completely fluorless, and over the last several years, we've kind of gotten used to not having to wear leads and not using fluoroscopy for a lot of our ablations, and this technology allows us to continue working in the non-fluoroscopic space, but with some of its own caveats. The catheter is relatively stiff, it's relatively difficult to get it to where we want to go, and the time for the ablation is about the same as it would have been for radiofrequency ablation. It doesn't really save us quite as much time as the other energies. I always like showing nice images, and so in time for release of this catheter, Biosense Webster came up with a new version of registered ultrasound using AI to allow us to collect multiple different views. The view that you see here is views from intracardiac echo, recording images, and then AI looks at all of these images, understands where the contour of the chamber is, and allows us to create a three-dimensional chamber without ever being in the chamber. We were actually first in men for the first version of that catheter in 2007. We've been using it ever since. This is just a kind of a cool extra that now allows the system to do it relatively quickly and independently. And that then allows us to move that catheter in a pre-created three-dimensional space. When the catheter is in the heart, we can monitor the circle of the Inspire catheter as we move it from vein to vein to vein. We can also address the posterior wall and other regions of the heart if we need to. But again, it's a relatively stiff catheter. So far, I think across all of us, we've only done about 4 or 5 cases. Empirically, it takes for now as long as the usual procedure, but the upside is fully fluorless. A couple of words about hemolysis. So it turns out that we don't just lyse the myocardial cells, we do also lyse red blood cells. And if the contact between the electrodes and the tissue is poor, and some of the electrodes are in the blood pool, you may end up lysing enough cells to create enough haptoglobin to bummer up the kidneys. Now, we've monitored hemoglobin levels and creatinine in a few patients and have given patients additional fluid around the time of these procedures. And so clinically, we haven't seen this as an issue in anybody we've ablated to date, but something we need to watch. And the other issue is, so long as we stay around the pulmonary veins, there's really no risk to the coronaries. But it turns out, for whatever reason, that if you deliver pulse field energy very close to a coronary blood vessel, it can go into spasm. Now, to date, there are no records of somebody having a myocardial infarction because of this. But, the operators noted early on that when they took this pentaspline, this is what that catheter looks like on X-ray that I was showing you from Boston Scientific. If you put it on the atrial flutter line in the right atrium and you try to ablate there, the right coronary is right underneath it, and you can cause coronary vasospasm. And to prevent it, we give the patient 2 to 3 milligrams of nitroglycerin as a bolus, which is a lot, and requires a significant phenylephrine chaser from the anesthetist to make sure that they still have a blood pressure to allow us to do all of this. But, we're learning as we're going, and a number of centers are using this technology for this purpose. US, since releasing the technology last year, similar to Manifest, collected a number of cases of experience with the 3 different pulse field systems. And again, the most important points here were that based on this registry, the death rate with PFA was much lower than that with RF. Again, this rate, this is the rate among reported cases. This is not a rate among everybody having ablation done. And that rate is about a quarter what they observed with radiofrequency energy. And there was 0 esophageal fistulas and 0 pulmonary vein stenosis. So that's where we're at with PFA. I'm going to bring this up. This is a QR code that links to a microsite that we developed with some patient education resources for our patients. All right. Well, thank you very much.